Well, ladies and gentlemen, let's give a round of applause for the kidney specialist, Dr. David Rodriguez Buritica. Thank you very much. Cheers.
Thank you again. Thank you, everybody. And thanks again for the association for this invitation. It's always a pleasure to come and see old friends and new friends. Is always good. Good. So today we're going to be touching base a little bit about kidney health in GSD. I'm going to, again, focus more on GSD1, but I'll touch a little bit on other forms of GSD. These are my disclosures. Again, I participate on research funded by Ultragenics and Moderna. And what we're going to do today is, again, it's a very informal talk, open for questions. I'm going to review some of the kidney functions, at least the ones that are related with GSD, and then touch on what are the aspects that we have to be vigilant about kidney health throughout the age, no matter what type of GSD you have, but what are the key points that you want to remember and how to act on it, how to try to prevent as much as possible. This is just a brief description of the important aspects of the kidney. We know that the kidney produces the urine, and it does produce the urine filtering blood. And one of the main areas on the kidney that filters the blood is sort of this tuft of blood vessels that is called the glomeruli. And initially, there is some filtration of the blood there. What is filtered there is the blood remains with large size of protein, but small size of protein can pass through that filtration process, and certainly a lot of liquid that is rich on electrolytes, glucose, amino acids, and then that filtrate goes through a series of tubes that eventually go bigger and bigger in diameter, and through the growing through those tubes, then some of the content of that initial filtrate gets reabsorbed into the kidney tissue and then goes back into the blood. So what we see is a very complex process of producing the urine. And for GSD1A, for instance, or GSD1 in general, we see sort of issues not only at the glomeruli, the tuft of blood vessels, but also problems in the function of the tubules. And that's one of the many functions of the kidney, but we know that there are other ones. I'm not going to list all of them, but I want to just discuss on the ones that are relevant for GSD. And the kidney is also very important organ that produces hormones. And one of the very important ones for the health of the bones and absorption of calcium and phosphorus is a vitamin. So an activated form of vitamin D that, in order to be active, is not only producing the skin while we get sun exposure, it also has to go through the liver, where it is semi-activated. It is converted in what we call 25-hydroxyvitamin D, and then it goes to the kidney and then is hydroxylated at 1-hydroxylase vitamin D. And it's only this form that is actually active in terms of helping absorption of phosphorus and calcium at the level of the bowels. So it becomes a very important hormone for bone health. And that's why bone health is something that long-term we worry with GSD. And it's not just for GSD1 here, it's also important, very important for GSD3, that we have good levels of vitamin D and that there is this process of activation of vitamin D in the kidney to be able to hold to calcium and phosphorus that ultimately are going to be the minerals that are going to make our bones strong and healthy. In addition, the kidney is also very important of producing another hormone that also causes the bone marrow to produce red blood cells. So when the kidneys are not working well, and this is usually a problem that happens later on into the kidney function, when we lost a lot of kidney function, then there is also poor production of this hormone that is called erythropoietin. And this hormone is responsible for making the bones marrow produce red blood cells. These are just some of the hormones that the kidney produces. The kidney produces other hormones, but these are the more relevant. Now, we know that in terms of glycogen accumulation, it's not only accumulation of glycogen in the liver, there is also accumulation of glycogen in the kidney. And that accumulation of glycogen sometimes is out of our control, sometimes through the diet and being very rigorous at the takes of the carb intake, we're able to reduce that accumulation of glycogen in the liver. Unfortunately, it's not the case for the kidney. This is an aspect of any GSD where we still don't have a good way to reduce accumulation of glycogen. And that accumulation of glycogen also plays a role in some of the problems that we see long-term in terms of kidney dysfunction. So it's something to pay attention to. And similar to what we see with the liver, when we see enlargement of the liver because there is accumulation of glycogen, we also see the same for the kidney. Whenever we do the ultrasounds to measure the liver size, we also see that the kidneys of somebody with GSD, particularly GSD1, they have larger kidneys. We don't necessarily do that on a physical examination. There is no way for us to really feel the kidneys, but if we do the ultrasound, that's what we encounter. So it's no surprise, as it's not a reason to get extremely worried that eventually the kidney size is larger than somebody of the same age. But it's something to pay attention. It's telling us that there is this glycogen accumulation. And like I mentioned, the kidney is also responsible for small percentages, 5 to 10% of the maintenance of glucose in the blood. The kidney is also able to typically, when there is no problem like in GSD, to produce some glucose and be able to maintain the glucose levels. Unfortunately, that's something that when you have GSD is limited. And there is also accumulation of lactate in case of GSD1 that we think is one of the reasons why we see so much kidney dysfunction at some point in GSD1 compared to other forms. But there are other factors that cause kidney dysfunction. It's not just the accumulation of glycogen, it's not also the production of lactate. There are other factors that play a role. Uric acid and high levels of uric acid also long-term eventually will cause what we call a uremic nephropathy, and that will long-term harm some of the functions of the kidney. With very poor control, there may be cysts in the kidney that may affect the function of the kidney. The first thing that we actually see in terms of kidney dysfunction is something that we call hyperfiltration. So that filtration at the level of the glomeruli, what we see very early in the course of GSD1 is actually the kidneys are overworking. They're filtrating more blood than what they typically do. And this is the very first finding in terms of kidney dysfunction in somebody with GSD1. There may be also accumulation of calcium and excretion of calcium in the urine, and long-term, those accumulation of calcium that could be seen like deposits of calcium or kidney stones in the kidney or in the rest of the tubes of the of where the urine goes through, then that causes eventually problem, may block the urine, and that blockage of the urine may cause problems upstream in terms of the filtration of the kidney. And long term, if we don't do anything about it, then what we're going to see is that it's decreased function of the glomeruli and eventually kidney dysfunction, kidney failure, where we have to talk about a kidney transplant at some point. As I mentioned, the accumulation of some crystals play a role in the kidney dysfunction that we see, particularly for GSD1. And it's not only uric, it's also calcium, or it could be other forms of crystals. These crystals can be seen by ultrasound if they are the calcium deposits, but other forms of uric acid accumulation are actually not necessarily seen by ultrasound. Interestingly, what we see in GSD1 in the kidney is very similar to what we see for a condition that is actually the opposite, diabetes. It's the same steps in terms of progression of kidney disease. Even though we're talking about conditions that are two opposites in what we see in the blood, with diabetes having high blood sugar levels and GSD having low blood sugar levels, what we see inside of the cells is actually a very high flow of glucose going through the different metabolic pathways. And that is probably the reason why we see the same type of progression long term if we were to see GSD patients or if we were to see patients with diabetes, type 1 diabetes or type 2 diabetes. It's diabetes where you need to receive insulin early in life, or diabetes where you just manage with diet later on in life. It's the same process. And the exact understanding of why that happens is not well known. Again, one of the postulates has been that is that increased flow of glucose inside the cells, production of lactate at higher levels. But there is probably other factors that are playing a role there. What is important and an advantage of follow-up of patients with GSD1 is that many of what we do for patients with GSD1 in terms of screening, treatment, kidney protection, comes from experiences that had already been applied and being effective in GSD, in diabetes. And it's always good to actually follow up what is going on in terms of the diabetes world for kidney protection, because eventually that may be useful, for instance, in GSD1. And that was the case for the use of EMPA or dapagliflozin for GSD1B. It was originally a medication that helped excrete glucose in the urine to lower the glucose levels in the blood, but it turned out to be a good treatment for the neutropenia associated with GSD1B. And there may be other benefits down the road of EMPA or dapagliflozin, SLG2 inhibitors, in the kidney, not only for GSD1B, but in general for other forms of GSD, if we're applying the knowledge that we have right now coming from the adult world on diabetes. And as I mentioned, the set of steps in terms of what we see kidney dysfunction apply for diabetes or apply under poor control or apply for GSD1. So the first thing that we see usually around childhood is hyperfiltration, overworking of the kidneys. The kidneys are filtrating more blood per minute than we would like to see. If we don't do anything, eventually what we're going to see is a spillage in the urine of small proteins, microalbumin, then larger proteins. If we don't do anything, then those glomeruli are going to start shrinking and being less effective filtrating blood. And down the road, the last step will be a frank kidney failure, where again, we're going to be talking about a kidney transplant at some point. So if we were to see those steps and compare them between diabetes and GSD1, we'll see the same progression. And if we were able to improve metabolic control. Same thing. We can delay the onset of many of these problems. We can see actually improvement of many of these problems at some point if we see improvement of metabolic control for most of the problems. Like I mentioned, the first thing that we see is hyperfiltration during childhood years. But also we see that those patients eventually have low levels of citrate in the urine, and when there is low citrate on the urine, there is increased risk of kidney stones. So make sure we check for citrate in the urine, and citrate is something that we can correct at some point. We can replace citrate and achieve better levels and decrease the rate of calcium deposition, kidney stones, and affecting the kidney failure, kidney function that way. During teenage years, then we may see, and it's important to look for presence of microalbumin or eventually albuminuria or protein in the urine, frank protein in the urine. And down the road, we eventually see that if we don't do anything about it, then those glomeruli are going to be shrinking, being very less effective, filtrating the urine, and this is something that we want to catch and treat early. How do we know that those processes are happening? How do we conclude that somebody has hyperfiltration? It's typically because we measure a creatinine level. Creatinine is a substance that comes from the muscle and is freely filtrated in the glomeruli. But if we see those levels being low, it's because we're hyperfiltrating, typically. We can measure the citrate in the urine, and that's how we conclude that there is a low citrate. Later on, we can actually measure the protein, the microalbumin, the protein or the albumin in the urine, and a random measurement is good. But if we see that is protein in the urine, then we have to investigate a little bit more. So it's always better if we get a random measurement that doesn't make sense or that suggests there is protein in the urine, which is an easy test to do, then it's always better to actually do 24-hour urine to get a better understanding of how much protein is being released per day in the urine and being able to measure that and compare that to other substances to get a better understanding. If we don't do anything, we're talking that we start seeing glomerulosclerosis. At some point, then the creatinine level actually starts going up, and we do not want to see that. We don't want to get to that level because that is telling us that the kidneys are being affected and then the glomeruli are being affected and they're not filtrating blood as much as possible. If we continue seeing low citrate level in adulthood, then this is something that it could be measured in the urine, usually on a 24-hour urine collection, and we can replace citrate. And if we see blood in the urine that persists, it's probably because there are kidney stones or eventually the glomeruli are sort of broken and they're filtering blood through the glomeruli and it's being spilled in the urine. So the typical trend is that during childhood years, we see that somebody has lower levels of creatinine. Then steadily, if we don't do anything, those levels are probably in the normal range, but then they're going to continue progressing, going up, 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 up. And when they're higher than the upper limits of normal, it's probably because there is something going on that certainly we couldn't prevent. Now, measuring the creatinine levels in the blood is an excellent test. Unfortunately, it doesn't always reflect the kidney. And the reason why is because creatinine comes from the muscles. And if we do not have a significant muscle mass, then we may have a low creatinine level. So it's not really a test that tells you for sure that there is a excessive filtration at some point. When we see low levels of creatinine, it also may relate to the fact that we don't have really a large muscle mass, which is not an uncommon finding in the GSD population 1, for instance, where we don't get enough protein in the diet. and because we're busy eating carbs to try to maintain blood sugars. So the message here is that we see a low creatinine early in life. It deserves attention. It deserves to be trended, but then we need to do additional labs to try to figure that out if that hyperfiltration is really occurring or not. So what do we do if we see, for instance, that those early processes of kidney dysfunction are occurring? So always have a low level of suspicion. Now, if you do have a poor metabolic control, then getting into a better metabolic control certainly is going to help. But even on patients with good metabolic control, unfortunately, there is an intrinsic process of the kidney that we cannot necessarily fix. But it's important to trend it because we can use medications to prevent progression of the condition. Now, we're going to need a better evaluation. So it's always good to get involved a nephrologist, a kidney doctor. Even though they are not familiar with GSD necessarily, they're very familiar on following patients with type 1 diabetes, for instance, in childhood, and the treatment is the same. So, and they feel very comfortable when that comes. So it's always good to have somebody local that eventually looks at the labs, is able to perform additional labs to define. I listed the other labs that help us understand a little bit better if there is hyperfiltration, for instance, which will be the first step in terms of kidney dysfunction, and eventually offering treatment for that to prevent progression of the condition. Some patients never develop hyperfiltration. The reason why some patients do and others don't, we don't know. This is something we want to understand better. It's always good to pay attention, keep it as a, again, back in your mind, and low-level suspicion. If you see a low creatinine level, then ask yourselves, probably we need a further evaluation, and there is something we can do about it. Improve metabolic control, be seen by the nephrologist, have a long-term follow-up. So there are many resources in terms of publications that have addressed this. The good news, again, is that if we detect this process early, we can do something about it. Call it metabolic control or use of medications, long-term follow-up. So, and there could be improvement of the kidney function, or that it doesn't continue progressing. What do we do if we notice hyperfiltration or eventually progression of proteinuria? So, as I mentioned, improving metabolic control is key. Use of some medications that are the same medications that are used for kidney problems associated with diabetes. You may have heard about these. Collectively, they are called ACE inhibitors. Medications like enalapril, lisinopril are used there. These medications are also used to control blood pressure. So it's important that as you start using them, your blood pressure is monitored initially. The good news is that at the level these medications are used to help protect the kidney, they really don't, it's very rare that they cause low blood pressure. So it's something to monitor at the beginning of the treatment, but if it doesn't occur later on, chances are that it's not going to occur. And these are medications that once you are on that, usually stay for a long period of time just to make sure that there is no progression of the condition. This is the case if we see hyperfiltration or if we start seeing early steps of proteinuria, microalbuminuria, albuminuria, or even frank proteinuria, protein in the urine, because the medications are the same and the approach is going to be the same. Now, one important aspect about the use of these medications is that we cannot use them if the patient becomes pregnant. They are contraindicated during pregnancy. What do we do if there is low citrate in the urine? Again, this is something we can measure. Then improving metabolic control is certainly there. Good water intake is also another factor for it to prevent low citrate, or at least increase calcium and deposition. And then we can actually provide citrate as a medication. It's not the tastiest medication, but it's something that is going to help long-term the kidneys. What do we do if we have calcium? So it's always important to monitor vitamin D levels. I mentioned on the two forms of vitamin D. Typically, we measure the 25, which is the one that we store, but it's not a bad idea to measure the 125. The reason why I'm saying this is if we don't have a good vitamin D intake, which is not uncommon for patients with GSD because of their diet, their dairy-free diet, then the storage of the vitamin D goes down, the 25-OH goes down, but once the kidney notices that the 25 is going down, actually it starts producing more 125. And so it's not uncommon that we see that somebody has borderline low vitamin 25-OH and then has a rather high 125. And that is telling you that you really need a little bit more of 25-OH. The problem is that if the 125 is high, that's the one that actually keeps on holds on the calcium and the phosphorus. So we may see a transient high calcium when that occurs. So the way is to fix the amount of 25-OH vitamin D that is very similar to the one that we take by mouth like a normal supplement. And then increased water intake is another good way also to help with calcium deposition in the kidney. And decrease salt intake, because calcium in the kidney and sodium are absorbed together. They are transported from the urine into the blood together. So the more sodium is there from the salt, then the more calcium we're going to absorb at some point. We have spoke about this during the afternoon, is what do we do with uric acid? Same thing, reach metabolic control. This is an aspect compared to the other aspects sometimes that we cannot control in terms of kidney disease, where we have almost full control. Improve your metabolic control, seek lower levels of uric acid, change your diet accordingly. You want to also make sure, it's been discussed earlier, that it's not just necessarily a good cornstarch intake, carbohydrate intake, it's also the type of food that you're consuming, food that doesn't have a lot of preservatives, that doesn't have a lot of purines or preserved foods. You eventually need to think about cutting down of those if the uric acid level. GSD-1B patients that eventually seek improvement of metabolic control with improvement of cornstarch and diet, if they don't see improvement of uric acid, there may be a problem with absorption of the carbs at the levels of the bowels. So there's probably some degree of bowel inflammation that is affecting the carb absorption. So maximizing empagliflozin is going to work for that. Eventually, using lower dosages of Neupogen G-CSF is going to may help with that. A good oral intake of water also helps with uric acid levels, and eventually we have to use medications like allopurinol to bring those levels down. But if the levels are improved, this is a medication that we can eventually remove. Now, we had spoken during the afternoon about other treatments that eventually will become available, that are available for GSD, that are mostly targeting the liver. I'm talking about liver transplant, or eventually once it gets approved, approaches like gene therapy or mRNA. Remember that we are targeting the liver. These type of approaches are actually just for the liver. So there may be some persistence of kidney disease, at least for 1A, that we're going to have to pay attention long term, regardless of what is your treatment. Same happened with the use of EMPA or dapagliflozin for GSD1B. We are targeting mostly the neutrophils. We're really not targeting the kidney with these medications. So it's always important to remember that there may be some component of kidney dysfunction that may continue progressing in the setting of these new therapies. And fortunately, the experience with liver transplantation, we know a little bit more, and what we know is that once the liver has been transplanted, assuming that the kidney was not transplanted, then the outcome in terms of kidney dysfunction is a little bit better, but still needs to be monitored. We're going to be working about an environment that probably there is no low blood sugars, but there may be other factors that continue to affecting the kidney function that we're going to have to pay attention to. So actually, what has been seen is that we still need to pay attention to uric acid because there may be elevations after kidney transplantation of the uric acid and those affecting the kidneys, or there may be problems with blood pressure that also need to be addressed because sustained elevations of blood pressure long-term are not going to be good for the kidneys. Definitely, there is no complete solution of kidney dysfunction once you have a liver transplanted or if you have received hepatocyte donation or if you, for instance, have removal of adenomas, not with a transplantation. There may be a better profile, but it's something to monitor long-term. Now, in terms of gene therapy, I mean, we don't have the final answer for that. We hope that a better metabolic control with gene therapy will result in a delayed progression or a lack of progression of kidney disease, but this is not an aspect that the studies have necessarily focused on. I think the good news in general is the experience has been that there hasn't any worsening of kidney disease during gene therapy trials with the experience that we have so far, but this is something to pay attention long-term for those individuals that receive some sort of gene therapy. I think we are all familiar with the development of treatment of the neutropenia for GSD1B with SLG2 inhibitors, empagliflozin, dapagliflozin, and how beneficial it has been for the improvement of the neutropenia, infections, and oral ulcers, and in general, bowel inflammation. But there are some aspects of kidney dysfunction that are very, very important. Is that, as I mentioned earlier, the activity of the EMPA is actually causing glucose to not be absorbed from the kidneys. So we're gonna spill more glucose in the kidneys, and that glucose is gonna carry water. And that is the reason why somebody starts taking EMPA and starts urinating more frequently. So one concern has always been that if we give EMPA, water intake is key. As much frequent times you go to the restroom to urinate, if you're on EMPA, you need to be drinking water to be able to recover that water intake and not to have chronic dehydration, because that chronic dehydration is really going to harm your kidneys. And that's the other aspect that the newer guidelines in terms of EMPA and GSD1B are recommending is pay attention every time there is a risk of dehydration. There has to be the consideration of either lowering the dose of EMPA or even stopping the EMPA. If we see that there is no production of urine, if we see that there is production of ketones on somebody with GSD1B, that will be relatively rare. If we see that it's vomiting or diarrhea, any other factor that is affecting the hydration and the flow of blood to the kidneys may cause more kidney damage. So it's important to remember that. And it's okay to temporarily stop EMPA until there is a good recovery and then resume EMPA at some point. Probably the neutrophil dysfunction is not going to go down immediately. It's going to take a little while to go down. So it's okay to stop for a couple of days until there is good oral intake again. I'm going to touch base on another condition we have discussed earlier. This is GSD 11, Fanconi-Bickel, because it's another one that has very important kidney component. And the issue in GSD11 is one of the transporters of glucose that is very important to transport glucose across the liver, across the pancreas, across the bowels, and across the kidney. From the filtrate from the urine to the cells, this transporter is not working well. So these patients actually spill glucose frequently, and that carries water, but also carries other minerals, mostly calcium and phosphorus and potassium, and amino acids. So these patients have from the beginning a severe kidney dysfunction, and because there is calcium and phosphorus spillage in the urine, then these patients not only have the problem with glucose that we see for other forms of GSD, but also have rickets. So we do have to supplement active form of vitamin D. We have to supplement phosphorus. We have to supplement eventually calcium, potassium, citrate. So different components that eventually affect the kidney function. And it is a condition where we have to be very cautious about the amount of glucose that we give, because they not only have hypoglycemias, they also can have hyperglycemias. And as I was mentioned earlier, the higher your glucose is, the more glucose are you going to release in the urine. So there has to be a balance there compared to other forms of GSD. So how do we treat kidney dysfunction in Fanconi-Bickel? Again, good glucose control is important. Here is why, for instance, using a CGM is important, because you want this balance between a hypoglycemia and hyperglycemia. You really want to try to keep your glucoses within range as much as possible. We have to supplement phosphorus, calcium, active form of vitamin D. We have to increase a lot of water intake because it's lost since there is glucosuria. There are some attempts of using EMPA, SLG2 inhibitors in Fanconi-Bickel, to be able to reduce the dosages of the other medications. But this is an area where we lack experience and we need more data to finally to conclude. But the preliminary information is telling us that using these type of medications also may be very, very useful for patients with Fanconi-Bickel, and we don't need to use as much medications as without using it. What about other forms of GSD? So basically muscular forms, GSD 3, 6, 9, 5, 7. What is the problem with the kidneys? The good news in general is the experience is that it's not as much as with GSD1, for instance, but I think this is an area that we need to pay closer attention. Unfortunately, we don't have long-term data sometimes to finally conclude. There may be some component there. We don't have to be as active monitoring at some point. The main reason eventually why we pay attention to this and kidney function is if there are episodes, acute episodes of rhabdomyolysis. If they're massive and the CK elevations are high, also the muscle proteins eventually will cause problems in the kidney and cause acute kidney dysfunction. And if that occurs frequently and is not prevented, then long-term that may harm the kidneys and cause more like chronic kidney disease than it needs to be pay attention. But the main thing is every time there is increased kidney dysfunction, acute kidney dysfunction, the message here is that it needs to be treated with aggressive hydration, make sure the kidneys, the CK goes down, and make sure we monitor the kidney dysfunction and that there is full recovery. Now I'm going to briefly share some of the observations that we have in our center. Again, we work at the University in Texas in Houston, where we follow a large group of patients with GSD1, and most of our patients, close to 80% of them, they have the common Hispanic Mexican mutation that is the one that I listed there. They're homozygous for that mutation, so they have the same mutation in both copies of the gene. And what we know that these particular mutation is that these patients do relatively well on cornstarch every 4 hours, with glycoside every 6 to 8 hours. If they space out the cornstarch, then we start seeing many of the long-term complications. They don't have as severe hypoglycemia as other patients that have other type of mutations. They do still have them, but it gives them a little bit more of time to act. And that's why some patients that are not under good control learn to survive without taking cornstarch every 4 hours, but then we start seeing long-term complications at some point. So what we start noticing is that we were seeing very early onset hyperfiltration before 10 years of life. Then that even though there was good metabolic control, it progressed to increase protein in the urine. And luckily, we don't have anybody with severe kidney dysfunction, but we wanted to know if this was a problem associated with this condition or not, with this particular genotype or not, compared to other forms of GSD1 that had other mutations. So this is still work that is going on, but what we did is that we look at all the metabolic factors, particularly the ones that had to do with kidney dysfunction, and we compared 3 different groups. Those patients that have 2 mutations with the common Hispanic mutation, the one that only had 1 mutation and another mutation, and patients that had none of the 2 mutations were one of the Hispanic ones. And then we compare, as much as it was possible, the progression of kidney disease on those 3 groups. And what we concluded is that there wasn't a major difference. There were some trends there, but they're really not strong to be able to call it that there is a good, what we call genotype-phenotype correlation. But this is an area where we're working closely and we're monitoring those patients long term. And as we get more patients, we're able to actually see what is the progression and relate that to their metabolic control. So I'm going to stop there and then thank you again for your attention. Thank you again for the invitation. It's always a pleasure to come to the meeting. And I'm going to open up for questions like we done it for the previous conversations.
What type of testing would you recommend for GSD1 adolescents with serious inflammation? What should you check for and how often?
So the question is regarding what type of test we recommend for adolescents with kidney stones. So certainly, so measuring the citrate in the urine is key. 24-hour citrate is the best way to go about it. Also, just a regular urine analysis to make sure there are no kidney and there's no blood in the urine. And eventually, if this is somebody that has had long-term kidney stones, you want to make sure that it hasn't harmed the kidney, so the glomeruli, so that there is also the glucose, the measurement of the creatinine in the blood is also key. Eventually measuring calcium in the urine the 24 hours. You can do a random calcium creatinine and get an idea, but if you're doing a 24-hour for citrate, you better get also a calcium 24 hours in the urine and compare it to the creatinine.
And how often would you do a 24-hour?
At least once a year.
David, I have a question. First, thank you for that awesome presentation. It was very helpful. So since you work with a lot of Hispanic patients, what is your opinion regarding the reference ranges? Because I have seen in the past several publications regarding reference ranges for creatinine, depending on the ethnicity of the patients. So have you noticed that the Hispanic population tends to have higher creatinine or not?
No,
Okay.
And that's a good point. And not for our patients with GSD. We're seeing, and I actually can't, let me see if I've had the table here, but I don't think we included the baseline creatinine levels, but the 3 groups were very comparable.
Okay.
So we didn't see that.
I noticed that some reference ranges in some Spanish countries are higher for creatinine. So I don't know if it's because the population or if it's the assay is different, but yeah, because of that I was asking that. Thank you so much.
Thank you.
My question is about bladder stones. Do you see?
Bladder, see, yes, so common, but it's typically more adolescents, it's typically more in very warm climates, weather, but not necessarily under 10 years of age, unless there is very poor control.
Hi, thank you. That was a wonderful talk. I've gotten a question a few times. Kidney biopsies, like I often will hear from nephrologists or patients coming for a second opinion. Do you feel that there's a point or indication where a kidney biopsy is warranted, or what's your threshold?
You know, I never send somebody for a kidney biopsy. I think in general, our understanding of what is going on with GSD help us prevent it at some point, and then implementing a good metabolic control may help a little bit at that stage. I'm not a nephrologist, so I wonder if that provides them with additional information to care for them. That is a good question. I just haven't encountered that particular situation.
I've had a few nephrologists bring it up, and again, it's that discussion, and I agree, I don't have a good answer either that helps. Thank you very much.
This cystatin C, how are you guys using that? And that's a newer biomarker, at least for hospitals ordering it away from the research.
Correct.
It coming out. What's your experience with that?
I'm doing it on everybody older than 3 years, because I think under 3 there are no good standards. And it's to be able to calculate the eGFR with a newer calculator that includes creatinine and then biometrics. And it still throws you 3 types of eGFRs, but communicated with our nephrologist, that was their best recommendation in those to get a better idea of what is going on. Again, I use it as an addition to creatinine because of the lack of reliability of just using creatinine alone in somebody who has probably decreased muscle mass. Yeah.
Have you seen it be helpful or adding that information?
I've seen differences in terms of the GFR once we incorporate the calculation of the cystatin. The good news is that I haven't encountered somebody has significantly has a significant difference when we used to use the eGFR calculation just based on creatinine compared to combined creatinine and cystatin. But I think long term, that's how nephrologists in general are doing, transitioning to use cystatin C. So I think long term, it's the way to go at some point.
Thank you.
Yeah. I think there was one here. Yeah. Just a certain.
So for one patient that we want to have a nephrologist physical follow-up because he's a young adult, the slide that you sent, which talked about the serum creatinine and the cystatin C and the eGFR, is there a specific set of blood work that you would recommend that's done, or that slideshow pretty much sums it up?
That sums up, yeah. And that's what we were talking about. And this is blood work, and it's to be able to do a calculation of the glomerular filtration rate with the newer standards. The nephrologists have been using the cystatin C relatively new, and it's just...
What is that filtration called again?
The
I'm sorry.
glomerular filtration rate,
Okay.
GFR.
Oh, GFR, okay,
Yeah.
got it. Thank you.
All right. I don't think we have any other ones. Thank you again.